Hi, everybody. Good morning, good afternoon, good evening, wherever you are. I would like to welcome you to this new broadcast of the Journal Club by the International Academy for Clinical Hematology. I'm Mohamad Mohty from the Sorbonne University and Saint-Antoine Hospital in Paris in France. And today I'll be joined by two top experts in the field we will be discussing in a couple of minutes, namely Professor Arnon Nagler from Israel and Professor Mary Eapen from the US and the CIBMTR. As you probably know, this is our first journal club after the summer break. So I hope that you have all enjoyed some good holidays, some nice vacations. You were able to take some rest, although I know very well that this COVID-19 pandemic has been quite challenging to many of us. And I know very well that many colleagues are still struggling with the pandemic, but hopefully at some point we will be able to get rid of this virus. The IACH Journal Club are supported by an unrestricted grant, educational grant by Takeda Oncology. And for the purpose of this post-holidays, I would say, Journal Club, the Scientific Steering Committee of the IACH has chosen this recently published paper in the journal Blood by Dr. Guptu and colleagues. And this is about HLA-haploidentical versus matched unrelated donor transplant with post-transplant cyclophosphamide-based prophylaxis. And I'm sure I don't need to spend a lot of time convincing you that post-transplant cyclophosphamide has become really a very powerful tool in terms of GVHD prophylaxis. And the initial use of post-Cy has been obviously pioneered in the haploidentical setting. However, given its feasibility, efficacy, effectiveness in the haplo setting, many colleagues thought that why not using it in other donor setting? And that was exactly the spirit of this wonderful paper, where they have used the registry data to compare the outcome of patients who received transplant using a haploidentical donor compared to those who received a graft from a matched unrelated donor. And what's really interesting that in both groups, post-Cy has been used for GVHD prophylaxis. So really very nice comparison. And we're lucky always with blood because you have very short, very straightforward key point. Here, the summary by the authors was that mortality rates were higher in the reduced intensity setting when patients have received a reduced intensity conditioning compared in the haplo setting compared to the mud transplant. Also, there was a higher grade 3 and 4 acute GVHD incidence in the haploidentical setting compared to the matched unrelated donor. And I have chosen two key figures from this paper. This is the outcome figure in the group of patients who received a reduced intensity preparative regimen. And you can appreciate the statistical, the significant difference you can see in these patients when it comes to actually disease-free survival and overall survival. Interestingly, when you focus on the myeloablative conditioning regimen, so in the group of patients who were receiving the MAC regimens, actually you can appreciate there is no statistically significant difference. And these are really important findings, especially that for the time being, we do not have a prospective randomized phase 3 trial comparing these two sources of donor with post-Cy, but I'll come back to this in the discussion. So I will stop here actually, and I will open the debate. And here I will ask Professor Nagler, because you are a top expert in this field, and actually you have published in the last few years a lot of EBMT studies comparing the different donor setting using post-Cy. So when you saw this paper, Arnon, what was your first reaction, and what were your thoughts, immediate thoughts?
So first of all, thanks for the kind invitation, and congratulations for Professor Eapen and CIBMTR for this important study in prestigious journal. I think that the importance of this paper is that we have only few papers that compare haplo and unrelated, both with posttransplant cyclo. So when we compare haplo to unrelated, we have the issue of the donor, but we have also the issue of the graft. So most of the haplo were done with bone marrow and the unrelated with peripheral blood. And besides this paper and few others, or very few others, usually the unrelated transplant were with calcineurin inhibitor and MMF without post-transplant cyclo. So the importance is that we still don't have a two-arm study, randomized study, but this is almost the closest that we can have comparing haplo to unrelated with the registry data. And I will say that the importance of this paper is in the title of an important commentary that this paper got from Professor Bacigalupo, and the title was that HLA still matter. So in this paper, in this comparison, and also in the EBMT data, still HLA matter, and HLA matched donors are usually preferable to haploidentical donors. Of course, the last word will be two-arm study. And the other novel aspect of this paper is the comparison of haplo and unrelated with post-transplant cyclo with reduced intensity and myeloablative. And indeed, the results are different. So reduced intensity transplant are different than myeloablative transplant, and Professor Eapen will, I'm sure, will talk about it and illustrate this point.
Thank you, Arnon. So, Mary, congratulations really for a nice piece of work, which will, I think, become highly referenced and will be really a good reference to all of us in the field. Can you just give us briefly the rationale for this study, and how you have walked through all of these data, because we know that thousands of patients now are receiving post-Cy for GVHD prophylaxis?
So, well, first of all, Mohamad, thank you very much for inviting me. I think this is an awesome session to have an international journal club for hematologists. So thank you for putting this on, and thank you for inviting me. So if I could take you back maybe 7-8 years, there was a publication from the CIBMTR that compared the early data of haploidentical transplantation for myeloid malignancy, where the post-transplant cyclophosphamide was compared to standard matched unrelated donor transplantation using standard graft versus host disease prophylaxis. And even though that study didn't show a difference in outcome, either in the myeloablative or the reduced intensity setting. The reduced intensity confidence, the bounds of the confidence interval just overlapped. It was just like a bare overlap, whereas in the myeloablative setting, the curves were sitting on top of each other. And one of the criticisms I had to live with for a very long time was you're comparing apples and oranges. So I would always tell my statistician, I said, you got to check the database to see when we have enough numbers to do apples to apples comparison. And it took this long to get the data set together. And we actually first a priori tested the intensity of the regimens separately based on what we saw in the earlier paper, even though there was nothing statistically significant in that paper. And it was clear that we couldn't put myeloablative and reduced intensity together because we just looked at survival and we could see a difference in survival. And so that's really what started all of this.
So excellent. So that brings me exactly to the question. And by the way, guys, please do not hesitate to send your questions using the Q&A icon or the discussion icon. I would be more than happy to share your questions and your comments with our panelists. So here you have alluded to this really clear difference between the reduced intensity conditioning group and the myeloablative conditioning group. So do we have an explanation? Why is this? Why post-Cy behaves differently when having different intensities of the conditioning regimen, Arnon?
So according to the paper, I mean, the non-engraftment was 11% with haplo and 3% with the unrelated. So mortality and non-relapse mortality were with reduced intensity was higher in the haplo, and then fungal infection was higher in the haplo in reduced intensity. And all of these factors were not in the myeloablative. So in the myeloablative, there were more bacterial infection, but not fungal infection. CMV was not higher in the haplo. And then the engraftment was the same. So we know that with reduced intensity, sometimes we have lower and slower, maybe engraftment. And in this case, I think the effect on GVHD, so it was a bit different, but actually in both cases, there was the same difference between haplo and unrelated for the GVHD. So I think that the difference was in the non-engraftment and fungal infection, and then the higher mortality with the haplo, and this was translated to better leukemia-free survival and overall survival in the case of the unrelated, in the case of the reduced intensity. And yes, I mean, there is interplay between the reduced intensity, immune reconstitution, which at least in the first month is slower for the NK and the CTL after haplo till the donor NK come with the Vargo paper, and the data is coming now from Rambaldi, the daughter. And so I think that this is the difference.
So Mary, do you agree on this interpretation?
The higher graft failure, I think, is what is driving the mortality in the reduced intensity setting. No, I agree with that. I mean, I'm sure you see the same effect in EBMT. If you generally look at haploidentical transplantation, and it's not primary graft failure, it's secondary graft failure that you're seeing in the reduced intensity setting. So no, I agree.
But 10%, we have a comment here, 10% of graft failure in the haplo setting. I mean, if I look to our own experience, I can't claim that we have up to 10% of graft failure. Is this about the period when these transplants were done? Because obviously, when I look into the papers, this goes from 2011 to 2018. Is this something has to do with the technique which has evolved over time? Because 10% looks to me quite high.
So single institutions or institutions that are versed in haploidentical transplantation will tell you they don't see that. So they don't see this high a number. But in the registry setting, you see it, and it's just like cord blood. You know, the cord blood centers will tell you their transplant-related mortality is acceptable, whereas when you extend it to other people, it's not quite the same. So I'm actually not sure. I mean, it's really hard to study a center effect in a more general setting. I know it's not a transplant period effect, and I know it is not the fact that these patients are all being transplanted in relapse, because generally we exclude patients transplanted in relapse and only take the ones that have been grafted to calculate secondary graft failure. So there is something going on, and a question just popped up: was it because of marrow? It is not, because, you know, in both cohorts, about a quarter received bone marrow. Peripheral blood was the predominant graft, so it's really not a graft issue. But we do see secondary graft failure, and
Absolutely, 26% received bone marrow in the haplo group and 12% in the MUD group.
It's not a graft thing that's been looked at.
Okay, so let's move, Mary, to the higher incidence of grade 3 and 4. In general, post-Cy has been shown to be extremely powerful in reducing severe acute GVHD. And here it looks like that it's not the same message. Again, what is your interpretation of this higher rate of grade 3 and 4 acute GVHD?
So it's a comparison with another group, right? And that's where histocompatibility comes in. So a haploidentical donor is a valuable donor resource if you don't have a matched sibling or a matched unrelated donor. But there are problems with donor-recipient HLA disparity, and I think that's what's being brought out in this paper, because you basically have two gold standards. If most people would agree that a matched sibling and a matched unrelated donor are really the gold standard donors, because you can't get any better than that. And so when you pivot a donor that is a partial match, then some of those things come into play. And if you level the playing field by offering post-transplant cyclophosphamide to the other alternative donor, because otherwise the risk of graft versus host disease would have been much higher in the unrelated donor setting, that brought it down.
So what level of matching of the unrelated donor? Sorry, just to clarify to the audience.
I'm sorry?
What level of HLA matching in the MUD setting are we talking about, to clarify to the audience?
ABC, DRB1, DQ.
Okay.
DP was not considered.
Okay, excellent. Arnon?
I think that in our data also, almost in all the paper, chronic GVHD is lower with haplo. But in most of the paper, acute GVHD is higher with haplo. And so I would agree that the main reduction is in the chronic GVHD. And I would, it's also that what we see is that acute GVHD is higher with haplo compared to unrelated. And when we did a similar study, but we did not analyze by the differently reduced intensity. So Sanz from Spain is the first author in our comparison of haplo to unrelated published last year with posttransplant cyclo. In our data, 50% of the unrelated was with myeloablative and 50% was with reduced intensity. And then in the haplo, 60% was myeloablative. So we don't have the breakdown, but the results are very similar. And so we had that comparison we did also for siblings. So I think that this, I would agree with data. For me, it was fascinating that out of, Mary will correct me, 1,100 centers that participate or more, 50%, 50 centers in the States are doing only haplo. So, I mean, and not do any unrelated. This is true, Mary, I understand it right?
So let me ask the question differently, Mary. So today, because obviously if we have to perform a randomized trial, and we'll come to this, usually I would suppose that a given patient will have both a matched unrelated donor and a haplo donor, and then you would randomize and see what's going to happen. My best guess in this situation that those guys who received a transplant from a haplo donor, probably they didn't have a MUD, or maybe the other way around. People, may have had a haplo donor, but people have stick to the traditional match unrelated donor. So how do we account for the so-called bias? Because obviously, probably the haplo group, they didn't have a match unrelated donor. So they may have a course of their disease and prior therapies, which is slightly different compared to when you look for you search for an unrelated donor.
It's possible. So the best surrogate that we could use was the interval from diagnosis to transplant, and that didn't change. But by and large, most people would do an unrelated donor search, and there may be issues with obtaining that donor because not every potentially eligible donor on search is available, at least not in the US. The donor attrition rate is high. They may have chosen haplo. Some people might have just chosen haplo because that is their center preference. So those are things that are really hard to tease out in an observational study. But you rightly pointed to the complexity of doing a randomized study where one arm has a fully matched donor and the other, for most patients, there will be a donor, either a parent, a sibling, or an offspring. So that brings a lot of challenges, particularly in terms of trying to accrue, because you're really going to limit your population to largely Western European, people of Western European descent, because everybody else has a problem identifying a fully matched unrelated donor. Although a randomized trial would be the ideal trial, where you bring in, you can clear out some of these biases, I think it's going to be very challenging to do.
So here we have a question from Dr. Gomez de Leon saying, what about the socioeconomic status and ethnicity? He is claiming that persons without a donor are also at risk for worse social determinants of health. And I guess maybe he is alluding to the haplogroup, although we didn't see such a difference in the myeloablative condition. Any comments on the issue of role of ethnicity there and socioeconomic status? Mary?
So African Americans tend to have a higher incidence of graft versus host disease. And other studies, although African Americans weren't particularly teased out in this group, have shown that African Americans generally have higher mortality associated with transplantation. A lot of people have studied socioeconomic status. There's certainly plenty of data showing that socioeconomic status in itself is a barrier to access to transplantation. But once you get to the transplant center, by and large, it equalizes for the most part. But there are some studies that have looked at distance from tertiary center and what have you. So I can't really comment on how things are done in Europe, but in the United States, socially disadvantaged people have a harder time accessing care at a tertiary center. Why? I don't actually know, because the tertiary centers, by and large, academic centers tend to absorb a lot of cost and run at a loss, as opposed to going to your private HMO that does regular chemotherapy. But that access is a problem for socially disadvantaged. But whether this is all driven by social disadvantage, I don't believe so, because the majority of patients who undergo transplantation in the US are Caucasians. It is not representative of the US general population demographics, for lack of a better word. So if you're a minority, you somehow have impaired access to care. And that is across the board. Even for autologous transplantation for multiple myeloma, there is a problem with access.
Absolutely.
And
I think
I'm not quite sure if I answered the question, but
I think you have provided some very important points. Obviously, we have to really work hard to make access easier and try to soften, I think, or to minimize the role of these socioeconomic factors on the outcome of a transplant patients, obviously. So let's move now to the practical consequences of this work, which is about which type of donor should I choose? So here we have a few comments and a few questions, and I'll ask Arnon maybe about your practice today. So what is your current practice in your center when searching for a donor? And for instance, based on the findings from this paper, and if we're talking about a young patient where anyway your intent is to use a myeloablative conditioning regimen, then you would say, okay, I don't care, the results are the same, so I'll go to the easiest and quickest available donor. And on the other hand, if I have an elderly or more fragile patient where my aim is to go for a reduced intensity, then I need to take my time and figure out an unrelated donor. What is your current practice? And then I'll ask the same question, Mary.
So in our practice, and this go with this paper, still match unrelated is the #1 choice. In this paper, the patient were CR1, CR2. And so patient in CR, we start all the leukemic patient. Here was also MDS. We start upfront the search and we go for 10 out of 10. Yeah, but we stop doing mismatch unrelated and doing haplo. As for and so this is according to the paper and many other papers. As for the conditioning, we still don't change the conditioning according to the donor. I mean, I say reduce intensity myeloablative. So we will stick for unrelated and alternative donor transplant above the age of 55. We will not do myeloablative conditioning, especially because of the GVHD, the patients that are above 55 or elderly patients, when they have GVHD, the reserve usually is very low and they cannot, and most of them will die from severe GVHD. And so I will not say that I will play with the myeloablative and reduce intensity according to the type of the donor. although the difference is very striking and impressive, but we will not do it at this stage yet.
Our
Mary?
practice is somewhat similar. The leukemics have a donor search, so your matched sibling first, your matched unrelated donor, and then a haploidentical donor. The regimen is really based on the patient's comorbidity status as opposed to the donor type. So if you have a fit patient, generally with a comorbidity index of 2 or lower, a lot of people are tempted to use a myeloablative regimen based on, I know the data is mixed because there are studies in Europe that haven't really shown an advantage to myeloablation for myeloid malignancy, as did the North American trial, which was closed early by the Data Safety Monitoring Board. So it's really based on your comorbidity status. It's never tied to the donor. And the other caveat is, even though we do matched sibling, unrelated donor, followed by haplo, the GVHD prophylaxis is not post-transplant cyclophosphamide. That's not the standard. That's still very much an experimental thing, for lack of a better description.
Okay, so we have a quick comment here while we're talking about the choice of the donor. Well, it's quite striking in the haplodonor because everybody claims that the haplodonor is the guy sitting in the room of the patient, you know, and is easily available. However, when we look into the paper, actually the earliest time to identify, you know, when I look interval from diagnosis to transplant, was like 4 months, which means, you know, it took some time, and the median is 6 and 9 months, depending on the low, intermediate, high, very high risk. So it doesn't look to me that the haplodonor is so quickly available. Am I wrong?
No, you're right. It's not. There are challenges with identifying a haploidentical donor. There are many family members that show up, but some of them just can't donate. They don't want to donate. They don't respond when the swabs go out. You know, there are challenges. So it's not, theoretically, I think if you have a young adult and you have a parent, it's very easy. But beyond that, it becomes a little tricky. It takes time.
Wonderful. Arnon, do you think that based on the study, because we're reaching the end, I think we solved the problem and we have enough information to stick to this algorithm of fully matched sibling donor, fully matched unrelated donor, haploidentical donor, and maybe, I don't know, cord blood, mismatched donors? Or do we still need to perform these so-called state-of-the-art randomized trials? What are your thoughts?
So first of all, just for the previous question, surprisingly, although in the discussion we also always write that haplo is very fast, in the last analysis that I did for the acute leukemia, also it took for the haplo 5 months, and one of the reviewers you know, point to the discussion and say that 5 months is not so fast. So I would agree, this is our data are the same. And yes, because of the elderly patient. Second of all, status of disease matters. So we didn't talk about patients that are not in remission, but it can be different. And of course, for your question, I think that we need a randomized study because there are surprises there. In the paper, there is a lot of discussion and subgroup analysis, like Professor Eapen explained in this webinar, but also nicely in the discussion of the paper about the difficulties in randomized study, but still everybody agrees that or most of us agrees that we need the randomized studies because things can be different randomized study. One, we mentioned the Scott study that was surprise for many people in Europe. We have the Figaro study that was surprise to many people in Europe, that intensifying with influenza does not make difference. So I think that, yes, the gold standard is the randomized study. It will be difficult in this scenario, but it's so important question that I think that we need a randomized study.
Mary?
I agree with what Arnon is saying. It is challenging to do a randomized study. The one thing that none of us have addressed is the fact that nobody knows what the long-term consequences of 100 milligrams of cyclophosphamide are. In the grand scheme of transplant, this is relatively young data, right? All of the haploidentical set. I mean, it is, I agree, post-transplant cyclophosphamide is a very useful tool to overcome the histocompatibility barrier in the setting of a haploidentical transplantation. But if you're going to use high-dose post-transplant cyclophosphamide for unrelated donor transplantation, I think that should really be studied in the setting of a trial. The use of post-transplant cyclophosphamide for a matched unrelated donor is really as a GVHD prophylaxis agent and not to overcome histocompatibility. And you don't know what it does to the graft. Are you going to have graft exhaustion like you see in the haploidentical setting? I think those are all unanswered questions. So to simply say, we're going to use post-transplant cyclophosphamide for all unrelated matched donor transplants, I think that's an overstretch. I think it needs to be studied.
So assuming that, I don't know, you want to validate post-sci in the unrelated setting, so, and you want to do this comparative or randomized trial, what would you consider today as the standard GVHD prophylaxis in the control arm? And how do you compare it to post-sci?
That's a very good question, right? Because everybody has their favorite. You know, some people would avoid calcineurin inhibitor altogether. Others would say, you know, TAC methotrexate as the standard. It's some things are not so clear. Let's put it that way.
Okay, so we have a question here from Dr. Nayak. Is any experience of using post-sci dose less than 100? And he or she is commenting that toxicity may be less, and maybe this is an echo on to what you alluded to, that the haplo and post-sci story is relatively young. Also, I must confess, and we need to be fair, that the initial data from Paul O'Donnell and Leo Luznik are from 2006, 2008. So this is more than 15 years ago, which, you know, dealing with the high-risk diseases we deal with is quite fair amount of time, you know, to see the prognosis of, you know, an adult AML patient over the long term. So what are your thoughts about this?
So the lower dose cyclophosphamide, to my understanding, has been used at select centers in the United States, and that practice was abandoned. I have no personal experience with it. There were a handful of patients in this particular data set that got a lower dose of post-transplant cyclophosphamide, but we were unable to study that on its own, and it got taken out. That's all I can say. It was tried, and it wasn't tried at Hopkins, it was tried at some other institutions, and it was met with failure.
Arnon, any comment, any experience on this? I mean, there are some data, for instance, from Pazek et al. in BMT paper that was reduced a bit, I think, to 40 milligram times 2, so 80. And also, you know, it depends if you're going to combine post-transplant cyclo with ATG. maybe you can use a lower dose of post-transplant cyclo, and your group and Renier published now the cardiac toxicity with the post-transplant cyclo in haplo. So I think for those that believe that you need to combine post-transplant cyclo and ATG, you may reduce the post-transplant cyclo if you think it causes toxicity, and give some ATG in combination.
Well, excellent, guys. I think we can spend the whole day or evening debating. This is really fascinating. Well, one thing for sure is that post-transplant cyclophosphamide has really become a sort of a Swiss knife, and the transplanters are playing with it, I think, in such an amazing way. Although I think, and that was really the key message from this paper, is that things may appear more subtle, more complicated than what we would envision. So definitely, if we really want to improve the outcome of transplant patient, we need to pay attention to all of these details. Thank you very much, Mary. Thank you very much, Arnon, for accepting to join us today for this journal club. I have really much enjoyed it. I learned a lot from you. I hope all our attendees have enjoyed it, and thank you a lot for the comments and questions. Obviously, for the sake of time, we will not be able to take all questions, but I'm sure definitely you will be able to connect with the panelists at some point if you have a burning question. So with this, I'd like to thank you all for attending this IACH Journal Club, and I wish you a good evening, a good day, wherever you are, a good afternoon, and please stay safe and keep well. Goodbye.
Thank you very much.
Thank you.